So now that I've begun, I've assessed already, I'm ready to begin inserting the tube. I'm going to provide for privacy and make sure that everything is set up. Positioning is extremely important, so you want your patient sitting in a high Fowler's position. And now I'm going to explain to her what she's going to need to do as I'm inserting the tube. So Miss Gladys, I'm going to begin inserting it. I'm going to have you, when I start putting it in, you're going to feel pressure in your nose. I'm going to have you tip your chin down and take a drink of water and swallow, and that will help that tube pass down into your stomach easier. If at any point in time you need me to stop, just raise your hand and we will stop. As the nurse, you know that you could potentially insert the tube into the trachea. Typically when that happens, you're looking for symptoms such as shortness of breath, extreme watering in the eyes, gagging. Patient can turn blue very quickly. You'll want to monitor the pulse ox. If you have any inkling that you may be in the trachea instead of the esophagus, immediately remove that tube and begin again with a new tube. Okay, so I've provided for privacy. I already have my tube marked. I have a piece of tape set up ready to go that's split in half. The part that's split will wrap around the tube. So I have that ready to temporarily anchor. I've moved over all my supplies here and we're about to begin. With the lubricating jelly, you want to lubricate at least the first 2 to 3 inches of the tube, and that'll make it easier for it to pass down. Okay. I like to start by having my patient tip their head back a little bit as I enter the nose. Okay, Miss Gladys, it's going to feel a little bit uncomfortable. I'm going to begin. So I'm going to have her tip her head back. Typically, when you get to the back of the nose, you'll feel a bit of resistance. When you get there, stop and have them tip their chin down a little. And now is the point, if you have someone with you, you can have them give them a sip of water so that they can swallow. If not, I'll just tell the patient, go ahead and swallow. Good, keep swallowing. We're almost done. And I'm going to advance the tube all the way down until I hit that little place that I've taped that I know that when I checked for placement, how far. So I'm there. Okay. I'm not noticing any gagging. It passed quite easily. I'm going to temporarily anchor it kind of loosely to the nose. If you have a patient care technician too, they can help you with this or hold the position. And I'm going to anchor it so that it is not completely secure, but it will hold in place should they sneeze or move. Once I've got it temporarily secured, I want to check the pH of the gastric secretions to ensure that I am indeed in the stomach. So I'm going to hook my piston syringe to the tip here. This is the anti-reflux valve that lets air escape out but not in, and then you also have this port. So I'm going to push this into the port and gently aspirate some gastric contents. Gastric contents should be green or yellow. What you do not want to see is any blood or coffee ground emesis, which is a darker kind of looks like coffee grounds, which is blood in the stomach. You really only need about 3 to 5 milliliters, so about as much as would fill this tip. Now I've got my pH paper that I'm going to put a little bit of the gastric secretions on, and what I'm looking for it to turn a grassy green color, that the secretions are acidic, that's consistent with the stomach secretions, and I want to look on here. Typically between 6 and 7 would be gastric secretions. So it is grassy green. I'm pretty confident that I'm in the stomach. So now I'm going to more securely anchor this tube. The physician should also order an x-ray called a KUB, which is the gold standard for placement. That's a kidneys, ureter, and bladder. Now the KUB will look at the stomach and it'll show radiographic evidence that the end of the tube is indeed in the stomach. So we have this completely anchored. We've checked placement and now we're done. If the physician's ordered the tube to go to suction, now would be the point where I would hook it up, and it's typically to low intermittent suction. Because the gastric secretions are rich in electrolytes, we don't want to remove too many secretions too quickly. So low intermittent will be just a slow, steady pulling of that gastric secretions, which is important because if they don't have normal bowel function, which can happen with a bowel obstruction, those secretions just sit there and the patient will continuously vomit until we put in the tube. So I've hooked this up to suction. Now I'm going to go ahead and back and reassess my patient. Okay, Miss Gladys, we're all done. I know that was not a very pleasant experience, but you handled it very well. How are you feeling now? And she says she's feeling a little bit better since the tube went in, a little less nauseated. So now I'm just going to get rid of this towel for you. We'll put your bed back down. We've got your side rails up. Here's your call light. Is there anything else that I can get for you right now? And she said no. So I'll come back in a little bit to assess her. Now the next and the last final step is going to be, of course, documentation. So with documentation, you want to include the size of the French tube. So we just inserted a 10 French tube into the patient's right nair on the first attempt, and that she tolerated well. I also want to describe how I checked placement. So I'll document that the pH was 6.5 and that the physicians ordered an x-ray and the x-ray is pending. You also want to document what came out of the tube. So if you hooked it up to suction, how many milliliters of gastric secretions and what was the color and the consistency of those secretions. And that's it. Thank you.